Great Congress, you know, we've got some fantastic live cases today. These are my disclosures. So before I start talking about small bowel bleeding, I need to, celebrate, because this is a celebration. We've celebrated 23 years, coming on to the 24th years since the birth of double balloon enteroscopy, which was the thing that changed everything. And this is the first publication of my mentor, who's like a second father to me, Hironori Yamamoto, in 2001. My goodness me, it's ages. And this was a simple but absolutely genius idea. Simple but genius. So you literally have a tiny latex balloon that anchors, and similarly you've got a balloon on the overtube. And together they actually work to grip the small bowel for it not to stretch and move away from you. And you also, this is the clever bit, when you pull back with both balloons inflated, you plicate. So with a 2-meter long endoscope, you're able to dive deep and deep and deep, and you're able to scope the whole of the small bowel. And this is Hiro with his prototype. Was given to another company who laughed at him, and then he took it to the company which ran with him, and the rest is history. And this is us, like father and son, and it's a really beautiful story that has translated into a story of institutions. And this is why he's always our special guest star at the Advanced Endoscopy Masterclass, which we usually hold in London every year, but this year we're going to hold in Malta from the 11th to the 13th of June, so be there or be square. Now, it's a celebration because the technology has advanced so much since the birth of double balloon. This is the latest generation scope, which is designed to dive even deeper with fantastic optics and even a water jet. And it also has beautiful imaging modalities that allow you to detect pathology and to treat. And these are the technical things that help you. And this is also a newly designed hood that helps you to keep that few millimetrics away and see things better. And it's a tried and tested technology. Of course, it's been paralleled by technologies such as capsule, which have incorporated artificial intelligence and the advances with imaging, but these are not competing, these are complementary. And when you need to get there, this is where double balloon comes in. It allows for direct evaluation, biopsy, endotherapy, and making a difference. And after 23 years of experience, it's proven that it can do things well, saving patients big operations. And the evidence shows itself. This is our data. No, it doesn't take forever to do a double balloon. In our unit, we take only about 40 minutes to 35 minutes, and we dive really deep. And it's extremely safe, and when we want to see the whole of the small bowel, we can. And it's incredibly safe and effective even under extreme conditions. This case of mine made it to the pages of the National Geographic. This was the height of COVID at Roll Free, and we had a patient with severe bleeding from the small bowel who couldn't have a transfusion because of religious beliefs. And we went down, we treated him. He had a hemoglobin of 35, and now he's got a hemoglobin that's higher than mine, which is in theme. So we dive into small bowel bleeding. What is it? It could be overt or it could be occult. Okay, overt is when you see the melena or the fresh red. Occult is when you get the iron deficiency. And it's still a problem, you know. Up to 10% of cases of bleeding come from the small bowel. It still poses challenges in 2025 with high transfusion requirements, making patients sick, decreasing quality of life, and tremendous costs from every front. So what do we do, Chair Sarah? What do we do? Do we repeat an upper GI endoscopy? Do we do a colonoscopy again? Well, it depends on the quality of the lesions, because an upper GI endoscopy done very hastily can miss things, and these are the things that miss. So quality is key, and this is reflected in our ESG's performance measures for upper and lower GI endoscopy, and also for the small bowel, our guidelines, our updated guidelines, and our technical review. Now, think about the small bowel. If you've got an elderly patient, the chances are that they're going to be bleeding from small intestinal vascular lesions or angiectasias. In a young patient, especially if it's overt GI bleeding, it is a tumor until proven otherwise. And you have to have a low threshold for cross-section imaging, because capsule can miss things, okay? Right, and then we go down with the double balloon when we find something on imaging to actually treat it. So let's look at the different modalities that help us. So capsule, it changes things tremendously, but you have to do it on time. And our guidelines state that you have to do it within the first 24 to 48 hours. Otherwise, you miss the boat. Ideally, as soon as possible. Okay, and it makes sense. You're going to find the thief in the night. And this is reflected in our guidelines as well. But, you need to also think of cross-section imaging. Because if you've got a young patient, I've told you, you can miss that tumor. And that is critical to find, because that can make a huge difference. You can even dive straight to double balloon if you want to, in certain circumstances when the patient is really bleeding. And capsule can miss things, okay? There are many missed lesions. So, for example, this is a gist that was extraluminal but contained its blood supply within the lumen. So it was bleeding intermittently, and no one would have found this had it not been for cross-section imaging. And capsule can miss things. This is someone who was bleeding out every so often. He had a history of vascular surgery, and it was only seen in one frame. This is an aorto-jejunal fistula. Okay. So they have good concordance, so we've proven this, and in most cases we direct double balloon enteroscopy by the findings of the other imaging, okay? So this is a proposed algorithm which we modified even in the European side. So if you've got overt bleeding, you're going to go more down the interventional route rapidly. If you've got non-overt bleeding, then you can take your time and play and observe and repeat and blah, blah, blah. So some case examples, so these are vascular lesions, we call them angioectasias, and how to treat them. So when we're down there with double balloon, non-contact APC is the thing that you should do. And my record is about 300 I did in Mexico when I was doing a live session. If you've got a pulsatile lesion, don't APC it, just clip, okay? And a good descriptor is the one developed by Professor Yamamoto and Yano. Pulsatile lesions you clip, that's the Seville classification. Technical tips and tricks, non-contact, use low power, the small bowel is really thin, you can perforate with APC, and don't put in too much gas because you'll distend the bowel and you won't get very far. And this is me doing that thing in Mexico, 300 angios. We can also help young children with this extremely rare disease, blue rubber bleb. Terrible, terrible, terrible disease. And systemic therapy does little, usually, for the small bowel when they're bleeding. So we've started cold snaring these. Before we used to be scared of them, we didn't know what to do, but I've discovered that you can cold snare them and nothing happens. And this is us at Great Ormond Street. So some other cases, so this is a jejunal diverticulum, if this video plays. So when you've got a diverticulum with a clot in it, a trick is to actually remove the clot that's in there after injection with adrenaline with the clip itself. Don't use a forceps or a snare to remove it. Just remove it with the clip, drop it away, and then clip the base of the diverticulum which is bleeding from. And this is us injecting the adrenaline, okay? I'll show you the clip. Removing the clot, we pull it away, drop it, but we've got our weapon of choice already in the house and we're going to clip it. Very good trick. Okay. We can treat varices, these big snakes, you know, when there's no radiological options. We can actually go down and inject some cyanoacrylate. They usually happen in patients who have cholangiocarcinoma, which is making their life really terrible. They're usually around the anastomosis, these big varices, and we can inject them slowly with glue to success. And don't forget your Meckels, or your very funny things like ectopic stomachs that cannot care where a Meckels would be and can bleed as well. But let's get down to business, because this is what we're really talking about, angioectasias. Arteriovenous malformations. And these you have to keep on hitting. We know a bit about the pathophysiology. It has to do with the blood supply to the small bowel, and it's commoner in age, chronic renal failure, and other things such as acquired von Willebrand's. But when we treat them, they tend to rebleed. We have to retreat them with double balloon. But now we've got some evidence that if you use octreotide or long-acting somatostatin analogues, they can reduce transfusion requirements if used alongside your double balloon. And this is the evidence that states this. In fact, they've got a place when you are treating them. I like this little technical frontline review, which was published recently, very recently in January, in Clinical Gastroenterology and Hepatology. And this goes around the pragmatic. I like pragmatic because it's helpful on the front line. And they classify small bowel bleeding in terms of how they behave over time. And it gives you a roadmap as well as to where medical therapy is going to be helpful and where it's not. And in these cases, those cases which are bleeding regularly and need several double balloons and need transfusion dependency, this is where the medical therapy will work most. So, in summary, Abed, Cesare, friends and colleagues, my take-home messages are, it's still a problem in 2025. Do a capsule after a negative upper and lower. Do a CTE, especially in someone who is young and bleeding overtly. You do not want to miss that tumor. Targeted therapy, timing is critical, and have room for medical therapy if need be. So this QR code will take you to the Endoscopy on-air double balloon volume that speaks all about this and has a tremendous amount of information and technical tips and tricks, which we led with Professor Yamamoto. If you scan this QR code, it will take you to our WEO session that is dedicated to small bowel bleeding and small bowel endoscopy. Read this from UEG that we wrote a few years ago, How to Avoid Mistakes, and come to our masterclass, which will be held in Malta from the 11th to the 13th of June 2025. Scan that QR code to register. Thank you.
Thank you very much, Dr. Edward. We'll keep the question to the end.
Thank you, Edward, for the presentation.